Good evening, everybody, and welcome to the latest MSK Kids Webinar, Medical Support for Arthritis Along the Age Spectrum. Tonight we've got Dr Navid Adib speaking to us, so we thank him very much for his time. My name's Buffy Squires and I'm the Community Engagement Coordinator here at Musculoskeletal Australia, and I'm very thankful that you're joining us here tonight. You'll see that we do a number of webinars here at MSK. Up on your screen now, you'll see the schedule for this year. We've still got 3 to come up, which may be of interest to you. They're not related to kids, but they may be of interest to you for somebody else, yourself or somebody else in your family. So keep an eye on our website for all of the details and how to register for those. Speaking of our website, I urge you to jump online and check out the kids page of our website, msk.org.au/mskkids. There you'll find lots of helpful resources for your child and the family living with JIA or another musculoskeletal condition. We've got resources for school. We've got a fantastic book that we commissioned called The Worst Pain in the World, with a lovely video that goes on along with that, which you can share with your child's school or kindergarten. It's a really nice resource. We've got general information sheets. We've got information about how to connect with other kids online that are living through something similar. So you'll find there's some really good information there for you and your family. You might also want to call our free MSK helpline, where we have 2 nurses, and you can chat with them about any issues that you might have. If it's a long time until your next appointment and you feel you really want to speak to someone, they're a great resource as well. So I urge you to jump online and you'll see all the details there. I'd also encourage you to follow our Facebook page, MSK Kids Ost. That's where I tend to update all the latest information on what's coming up. The next event we've got coming up is an online parent support group. We haven't tried this before, so this is a new thing for us. And the first one is on Wednesday, the 2nd of September. It's just a chance for parents to come together, have a bit of a chat online. It will be done through Zoom. They can talk about things that have worked for their kids, any concern that they might have, and share their stories with other parents and people who understand what they're going through. So if you'd like to get involved with that chat, just give me an email, send me an email. My email is Buffy, BUFFY, @msk.org.au, and then I'll send you the Zoom link so that you can connect with us. Tonight we have Dr Navid Adib speaking to us. Navid has been practicing paediatric rheumatology in Queensland since 2006. He graduated from the University of Queensland Medical School in 1992. He undertook training in paediatrics at the Royal Children's Hospital, Brisbane, until 2000, when he was offered a training position in paediatric rheumatology at Great Ormond Street Hospital in London. He trained there until 2002, when he accepted a fellowship at the School of Epidemiology at the University of Manchester, where he helped set up a multi-centre study in childhood arthritis and was awarded his PhD degree in 2007. After returning to Brisbane in 2006, Navid worked tirelessly to set up a service for paediatric rheumatology families in Queensland. Based at the Arthur House in Red Hill, he provides regular clinics supported by allied health professionals in Cairns, Townsville, Mackay, Rockhampton, Bundaberg, Sunshine Coast, Toowoomba, Brisbane and Gold Coast. It makes me exhausted just thinking about how much he is travelling around. Providing support for the kids in regional Queensland has been his passion, which he's shared by the people he works with, notably Zoe's Angels. His research interest in paediatric rheumatology is the outcomes of rheumatological conditions in young people. So without further ado, I'll hand the proceedings over to Navid. Thanks so much, Navid.
Buffy, thank you very much for the kind words, and everyone, thank you very much for inviting me to share my presentation with you tonight. The idea is to just provide a bit of flavor for everyone to know how kind of variable the presentations and symptoms in the world of pediatrics and young people can be, and hopefully after that we can go on just an introduction what I have been up to in the past few years in hopefully trying to set up a robust community service for pediatric rheumatology in Queensland, and hopefully hear other people's ideas if there are suggestions to make our service better in Queensland. I want to show you a video to start with.
We were ready to leave. Ashlyn's condition was getting worse. We didn't know what to do. Ashlyn and Cam would go to bed and I would sit up in front of the TV or do the folding and just cry because it was hopeless. We just felt so alone. My husband Cameron and my daughter Ashlyn and I live in Clermont in rural Queensland.
Wanna take you somewhere where the sky is open.
Ashlyn's had juvenile arthritis since she was 7, and it's been a rough trot out here. We had no idea what was wrong with her. We had no idea what was about to come.
Diagnosis of these conditions can be very difficult in remote areas and their treatment even harder.
Things continued to get worse, so we travelled into Mackay to see our old GP. Thankfully, he had Dr Adib's business card, and before you knew it, we were in Brisbane looking for a diagnosis.
Well, in case of Ashlyn, it was important to diagnose her as soon as possible, and treatment was available straight away after that. And unfortunately, the family had to stay back a couple of days more, and these are not small costs for these families.
At that stage, Ashlyn was so depressed it was very hard to get her out of bed. So when you've got a 7-year-old who's depressed, and the general consensus from a psychologist is that they won't see him until she's ready to kill herself, that's not good enough. Our kids deserve to have treatment.
I just feel that it's unjust that these people have got no services, you know, and there's still an enormous travel. It's a big dash to Brisbane normally.
We generally leave at midnight. It's a good 10-hour drive, and when you've got a child with juvenile arthritis and their joints are seizing and she's screaming in the back and she's trying her damnedest to get through the drive, it feels as though you're never going to get to Brisbane.
The stress is real, it's there. This is not just an illness for a child, it's a family illness because we're all affected by it. If they have a specialist that is permanently there or they're a hell of a lot more than what they are, then that stress again is taken off.
So it might be easy to just think, why not move? But it's not as easy as that. Psychology is a very important part of treating these diseases. Even if mum and dad want to move, how about how Ashlyn is feeling about all of this?
I think we were a good 9 months into the JIA journey by the time we'd had that first major contact with Zoe's Angels. Nat saw that we were in the Wesley, and from there we met with Di and we had a cup of coffee, and that was a special moment for us because we felt seen and we felt acknowledged. And we came back after Ashlyn had received her treatment. Her swim coach had presented her with a beautiful pair of togs and a card that Ashlyn still keeps beside her bed and reads it on her down days. And we went to pay for her swimming lessons for the term, and they refused our money. And they said to us, for as long as Ashlyn needs the pool, that we won't pay a cent. They're just so special. They're just so special.
Community is extremely important. It's extremely important, you know. Again, I wouldn't wish anyone to have to move from their community just to access treatment or just to access medical care.
Hayley and Matt have been amazing, and Matt has even offered to do lessons with Ashlyn on his days off. And then we've got Lauren, who is Ashlyn's swim coach, and she's just as supportive. Dr Sarah, our GP, and she has Ashlyn on her VIP list. Alan Scott, from our lodge president from the CFMMEU. It is so important that we have these people around us, because when it's bad, it's really bad. I can't imagine moving away from them.
Every 3 months I fly up here. Unfortunately, the disease doesn't wait, and if kids need urgent help, that may not be possible.
That's ridiculous to think that if a child's having a flare-up, that they could wait for 3 months.
I just find it, in this day and age, that shouldn't even have to be an issue. It shouldn't have to be, really.
The problem with treating these conditions in the outback is that the patients and their families are so far away that no one can hear their cry.
Having a doctor, having allied health or whatnot, where they have access to these areas in northern Queensland, it just makes it a lot easier for the family. There's no travel involved for the child, and we know that stress is a trigger as well for flares. So to me, it just makes sense.
The fact that Zoe's Angels is really pushing and fighting to get this doctor in Townsville, it means the world. It changes the way we would access healthcare for our children.
The government give very little, and we're doing our best to fill that gap. We're just trying to give these kids a life that is full and that can be lived to the extent that every child deserves to live.
Okay, this was a promo video that was basically put together for the gala event, which was a yearly event until this year, for fundraising for kids in Queensland with rheumatological conditions. And I'm sorry that we lost sound at the beginning of it. I hope it came across that Ashlyn is now 9. I think this was filmed last year, and I think the video demonstrated the isolation and the distances when we were to go and film this in Claremont. I went to Mackay with the crew, and so I had a car to drive from Mackay Airport, and I put the address, and the instruction from the navigator was drive for 300 kilometers. The destination is on your left, and that was that. The story was that there was a delay to her diagnosis. Unfortunately, they had to come to Brisbane for this to happen. The first procedure, which involved injecting Ashlyn's hips, was done in Brisbane at the Wesley Hospital. She improved after that. Therefore, that was a positive outcome. And up to then, there was all panic and the possibility that what if, like, no one can tell us what's wrong with our child. And after that, I think that was the beginning of a journey for the parents and for Ashlyn particularly to develop her illness and health perceptions, to realize that there is usually some treatment available, and hopefully we can make things better, and help will be on hand. The good news is that, why this was particularly like a heartbreaking situation was that Ashlyn had become very upset and very sad with this whole event, and as I said, thinking that there was nothing that could be done to make her better. And we tried to do video consultation with her GP and with the family, as you saw them, and suggested psychology to be done for her. And at that time, they were told that unless she's self-harming or suicidal, that she will not be seen. And that was a shock to the family. I think for people who have worked in the public arena, that might just indicate lack of resources, but from a family's point of view, I think that was a terrible thing to say to them. The other people that you saw in the video were Natalie, who's Zoe's mom. Zoe is a 11-year-old girl who's doing very fine at the moment. She's in Brisbane, and we're looking after her. She was very sick when she was younger to begin with systemic arthritis, and she has done really, really well and getting a bit of Australia's sun right now, and becoming nice and strong. And the older lady was Di Smith, who's unfortunately not with us anymore, but basically Di and Natalie have done amazing work. You saw the panel that was their board, and it is just a miracle that I think these people have got together, and they're devoting their time to fundraising for kids with rheumatological conditions. So in this session, I would like to talk about infancy to early childhood, and then later on to preschool years to adolescence, and the next stage, which is adolescence to young adulthood, and hopefully be able to conclude a few results. Just realizing, and this is the thing about pediatrics, pediatrics is not just one area. You know that we have got neonatologists, we have got early developmental pediatricians, community pediatricians, we have got various subspecialties, of course, as usual. So I think that reflects in care of kids with rheumatological conditions as well. The child is rapidly changing, and her or his needs are rapidly changing as well. Early years involve early development, and for those of you who have been involved with children education or health, you realize that early development is basically sort of setting the pace and paving the progress for that child in every sort of domain and in every aspect of their living and health, and ultimately quality of life. So in the preschool and elementary school, they will have certain social developments and skill acquisition, knowledge base expansion, and as we know, adolescent to young adulthood is very complex, and there are relationships, confidence with skills, and ultimately development of health perceptions. So this is a little video to show you, this child is about just over 2 years of age. This was in my training, and this child was from somewhere near London, and the family had to travel to London for a good 2 hours, 2.5 hours to get a frequent treatment for him. But it is really to show how challenging these conditions can be, but how adaptable the kids are, because it's a beautiful video in stages to show how well Ryan did.
That's it, you keep going. Right, you can stand up. Oh, that's brilliant. Good boy. Well done. Teething. Yeah, back, very back too. Good boy. Yeah. Well done. Very good. I do hope you got that. Practice myself. Wow. Can you touch my hand? Clever boy. Good. The other leg. This leg now. See if you can touch my hand. Okay, Chelsea, you can count.
26. 1, 2, 3, 4,
Well done.
5, 6, 7, 8, 9, 10,
Wait, someone in.
Yeah, sure.
I did, but I didn't know how to do it. I had to show you.
14, 15, 16, 17.
It's up to you. I'm just looking at you. You don't have to do something just because I'm looking.
29, 30.
Excellent. Great. The other leg. And Samantha's counting. Go.
1, 2, 3, 4, 5, 6, 7.
Can Zach do it first now? You're going to go backwards. Show everyone how you go backwards.
Well done. Everyone give Zach a clap.
21. Hello, Zach. 22.
Thank you.
23. 24. Up and down, Zach. 25. Woo. 26. Yeah, come on. 20. Oh, clever boy. And one more time. And stand up. Good boy. And one more time, sit down.
She is there, I think. My God, look at that. Just look at the Gosh. Woo.
You didn't even call it then. You climbed
No,
it.
amazing. You're a clever boy, aren't you?
Show us how you do 100.
Oh, good boy. You're very smart, aren't you?
Keep going. Good boy.
Clever boy.
That's in your pocket.
Is it going to be in the camera? Is it going to be in the camera?
We already got 2 though.
Oh, I can see you on the camera walking.
I see Zachary.
I can see you.
I can see Zachary, he said.
Yes.
So, so Zach had a very unusual condition, which is called Sappho syndrome, and basically, I think you realize that her right foot was clubbed, and that's because of severe swelling, and there was so much inflammation that all of his little bones basically stuck together, and it was as if he was given a joint. It's called arthritis, which means basically fusion of the joint. So as you could see in the beginning, he had lost his skills. He could not walk or stand anymore because of pain mainly. Then as he received treatment, but particularly with the good work of the therapist there, his skills one by one, he started bum shuffling first to mobilize once again, and then being able to stand up once again, and then finally being able to walk holding hands and being supported, and eventually being able to walk without any support. I had the pleasure of being in Great Ormond Street Hospital in 2005. I had finished there in 2002. But I went back for another clinical stint before coming back to Australia, and then I saw him, and he was just running everywhere, and he was just like you pretty much could not tell if you didn't know him that he had anything wrong with him. As I was talking about regression in developmental milestones, so it could be back to dependent walking. The cues are holding parents' hand and not being able to walk independently, cruising around the furniture again. back to crawling. Usually you can tell an antalgic pattern if they have got lower limb issues, swelling or pain. Sometimes they give up moving altogether because they realize it hurts too much, and parents often report that the child just stays in their bed, especially after waking up, and just is reluctant to move. And importantly, an observation is when they don't want to participate in play. And so all of those are basically alarm raisers, like signals basically that something is going on in relation to their joints or whatever reason for the pain. They could show irritability and pain behavior, as you heard him screaming and objecting to sort of being given therapy. They can become a bit clingy, they may night wake, and when the hips are involved, one clue is pain on changing nappies or being handled and held, like especially like if they are held astride the side of their parent. And bumpy car rides especially is the one that is another thing that parents describe that can make the kids cry and scream when they're going in the car. Eye symptoms might be cocking and turning the head to one side, in other words, to demonstrate eye preference. And the reason for that usually is that they cannot see very well out of one eye. Squinting in the sunlight, in other words, photosensitivity. And when there are flash photographs, it may show that there is a white eye reflex in the eye, and all of these should be considered as symptoms and signs of uveitis, which is inflammation in the eye. This was another young boy with also a rare condition called chinka, which basically is otherwise known as NOMID, which is neonatal onset multi-inflammatory disorder. These are conditions that there's a high degree of inflammation in the body, and the child can have from early infancy aseptic meningitis, which is the reason for irritability. This child just screamed for I think a few years before I saw him because he didn't have a diagnosis. And these are the early childhood photos. And the reason he was screaming was probably because he had a whopping headache as a result of chronic inflammatory meningitis that he had. There was no bug involved, but just inflammation in the around the meninges of the brain. You can see that he has got a sternotomy scar. So this is where his chest was open to be able to drain a pericardial effusion, which means basically fluid around the sac around his heart, which was constricting his heart beating, and that made him basically collapse and be in shock. So he had to be rescued with having this operation. You can see on the skin that there is this chronic rash, which is an inflammatory rash, and all of these features are the results of over supply of inflammatory cytokines in the body. Again, you can see that there is flexion in the knee, so there is arthritis associated with this condition, and indeed he had multiple joints involved. So in elementary school, there is difficulty with morning routines. I think it is difficult as it is, like when there is no rheumatological problem, to get the kids organized and make them remember their routines. But if you add early morning stiffness and difficulty in walking and mobilization, it just makes the problem a lot more difficult. Dressing, brushing teeth or hair might prove very challenging, and chewing, which might point out to the involvement of temporomandibular joints, which are these tiny joints across the mandible, or holding a cup, which may signify hand pain. Opening jars or bottles might become problematic. There's social issues at this age, such as refusal, medical assessment, and therapy might be difficult because they don't want to be hassled. They just want the condition to go away. Difficulty in accessing classroom stairs. Every school in Queensland, for some reason, has got stairs, and difficulty to sit for any length of time in the classroom. The girl that I showed you, Ashlyn from Claremont, mom worked locally, and in Claremont is as you could gather from the video, it's not a very big town, but whenever Ash's classroom was upstairs, and whenever she needed to go to the bathroom, mom was called so that she can come and lift her from her chair, take her to the bathroom down flight of stairs, and then again lift her and take her back to her seat upstairs. And I had to actually write a letter to the principal of the school and plead with him to consider bringing her classroom downstairs. And I mean, simple solutions like that sometimes can prove very difficult. Eventually the school came around and helped her very much, but we need to be aware of these difficulties. Then handwriting can be an issue with loss of function in the hand. Side effect of the medications. People like, I don't know, those who have any experience with having had methotrexate or having had children who take methotrexate. It's a good medication. It's very effective against arthritis. But geez, I have not seen one person who are not just jumping out of their skin when we tell them that it's time to stop their medication, hopefully, and being able to wean it off, because it just makes them feel sick and just unwell throughout the day. Vision can be an issue, again, with uveitis. They may need to sit closer to the front of the classroom. And then, of course, a lot of our social activities is around sport at school, so physical education and remaining competitive, but being accepted in the group. Like kids are like pack animals, basically, and as soon as someone displays evidence of being a little weak and not being able to compete with the others, very quickly they either get picked on or that they get forgotten and left behind, and that obviously very dramatically affects their psychology. And then communication with school is very important. So we're very lucky because the team that we have in Brisbane and other places as well, usually after having had case conferencing with them, will liaise with school and communicate with them closely to provide appropriate level of care. In other words, we don't want the kids to be overprotected, but at the same time, we don't want them like, you know, if they can't do physical activities, to be made to do them, because obviously they get affected by pain or fatigue. And the other thing is confidentiality issues at school. A lot of kids don't want other students to know that they have got a condition, because I think most kids just want to be like everyone else. They don't want to stand out. They don't want to be special for any reason. And unfortunately, when they can't do the physical role that they have, other kids may ask when they're allowed to sit on the side or do a different activity, what's the difference and why is it that such and such person can do the other activity. So it becomes really difficult all in all. In adolescents and young adults, disability is a huge issue, because more is expected from them as young adults. They may have been independent previously and they now lose their independence. Mobility around school, changing classrooms. Lockers are always in very sort of remote corners of the schools. And again, PE and sports participation and competitiveness can be an issue. Again, tiredness, difficulty with sleeping makes the matter more difficult. Alertness and routine medications and analgesics may interfere with performance of the child. Once again, peer relationship and family can be affected. They realize that they're not the same as other kids, and they just want the condition gone. Unfortunately, as a young person, they may not be logical. In other words, you may try to reason with them, but they may not understand your reasoning, and they just want the condition gone. And we talked about the pack mentality, bullying and teasing. Kids are extremely sensitive to look in inverted commas ugly or abnormal or deformed, but this is particularly a problem when they may get chin recession as a result of chronic involvement of the temporomandibular joint. If hands are involved and the small joints of the hand, because everyone can see your hands, they just absolutely hate that. They don't want to look that way. And then as a result, they start withdrawing from social contact, self-isolate, self-harm, even reckless behavior, or even not wanting to go to school. And then at the family level, rivalry starts between the siblings and taking up resources. So all of these are extremely difficult issues. So having spelled out a few of these problems, I don't have trouble convincing you that this is a complex problem, and we do need a complex plan, hopefully with the involvement of multiple allied health professionals. And the aim of this needs to improve quality of life. And this is one area that we always agree with the parents. If they're anti-medication, anti-vax, or whatever it might be, I think parents usually like to improve in their own way, or they accept our suggestions to improve quality of life of the child. So it's a good point to start negotiation and communication with the family. Obviously, it needs to be tailored to individual needs. Not all kids with rheumatological condition are the same. Those examples that I've shown you demonstrate that the kids have different, from JIA to SAPHO to CHINCA. These are different severity of condition, different needs. Importantly, we want pain control and adherence with the medications and to minimize side effects for them. Nursing support is very important, information hotlines. There is I've spoken about this many times in my presentation. I acknowledge that as a specialist, when I talk to patients, there is a difficulty in understanding the instructions, whereas if the same instructions are given perhaps in a different manner by a nurse or by the therapist, it's much easier for them to understand. So it's really important to have the story told by different people, hopefully emphasizing the same points. As I said, liaison with school is extremely important, and we need to reduce the burden of disease on the patient and family. Blood tests are particularly traumatic. Kids don't like needles, and one of the ways to help is simultaneous appointments with multi-specialty clinics or multidisciplinary clinics with various allied health professionals involved. And client support groups like Musculoskeletal Australia, Arthritis Queensland, every state has got an organization that will support clients. In Queensland, we're very lucky to have Zoe's Angels as well, which provide support. So medications always need to be reviewed so that it's made sure that they're for appropriate level, regularly assessed for efficacy, and when necessary, escalate. One of the important things is not to sort of do a minimal sort of pyramidal approach. In other words, it's more important treat to target to reduce the disease activity and normalize the joints as much as possible, which will then result in normalized function, and then we can reduce the medication as needed after a period of maintenance. But if, in spite of all of this, the disease activity is increasing, then we need to be able to escalate. And it's really important to communicate this with the parents and kind of show them the philosophy that you're using, so that everyone is on the same page and they don't sort of think that you're there to just give them medications all the time. It's important for them to know that there is an end to it, and we're chasing a target where when we reach that target, hopefully we should be able to back down on medications, etc. And steroid injections are really important in pediatric rheumatology when there is joint inflammation, because that's one way of preventing joint damage and maintaining range of motion, and physical treatment, as I have mentioned a few times in this presentation. And so improving quality of life I hope you appreciate the difference now between this picture and the previous one that I showed. This is one of my patients who is, I think, a student in nursing now, and this is from a few years ago, and she had a huge a deviation of her chin, but now after joint injections, her temporomandibular joints are working better, and she has got a straight smile and mouth opening. And then also, I mean, other things to throw in is patient or parent or carer's mental health consideration or general health considerations, and also affordability of health care for them. So basically, I'm saying that the care needs to be individualized, and it should be according to a plan that has been discussed with the family and with the allied health professionals. And different age groups may need different plans, and we need to communicate and anticipate health needs ahead of time. That's, I think, the art of giving a good service, and to involve the patients and families in a health plan, and have their inputs, because different things may make them happy and differently satisfied. And obviously we need quality transition services as well. I just quickly run you through these slides, being conscious of time. I think it just took me a bit longer to explain those initial slides. As I mentioned, and Buffy mentioned, one of my aims when I decided to do pediatric rheumatology in early 2000s was to hopefully provide a significant service for the state, and to have a robust community based service. I will show you Arthritis Queensland a few years ago published a paper that showed the further away from specialist centers, the longer it takes for a diagnosis to eventuate for the patient. And this is very true, especially in this day and age, not only because of the financial cost, but like, you know, I mean, I know that COVID-19 is a very extraordinary circumstance, but I mean, it just highlights the fact that it's very difficult to bring people to the centers and very expensive to do so. And if we have got clinics near their home, where they would be much more happier to attend, and hopefully we can intervene and provide good care for the kids, so that we prevent their joints to become damaged and hopefully have a better outcome for them. Again, in Australia, in most states, regional and outback services, populations are very sparse and great distances. And the longer this distance, less likely to be seen by the specialist clinic in a timely manner. And everyone knows about the congestion involving tertiary hospitals and how usually they don't accept the referral until the child is critically ill, or that there is a threat to a joint or a limb. In other words, there is a triage system, and the more severe cases take priority all the time. And so that's that action plan that I told you about in 2013. It was made for Queensland children with juvenile arthritis. And then this followed in 2014 with Time to Move, a national strategy to reduce the burden of JIA. And the basic recommendations are, there's a lot of detail in these slides, but the crux of it was that the child should be seen as soon as possible in a timely manner when they have got a rheumatological condition, and with the support of multidisciplinary clinics with allied health professionals, physical therapists, but also psychologists and nursing staff as well. And it was up to every state to develop strategies to make this happen and eventuate this plan. And so what I came up with, because I was fortunate to have a few friends who were in allied health. I will show you later on. And they helped to have multiple clinics in multiple areas of Queensland. Again, I'm showing you this slide to say that, you know, most of the population of Queensland is concentrated in the southeast corner, whereas I mean, there are many cases in far north Queensland, northern Queensland, in Mackay region, Fitzroy, etc. And the expectation is that population will grow exponentially over the next so many years. So this is the picture of the front of Arthur House. It's an old sort of business front, I think from 1902. It has been a business front in the region of Red Hill in Brisbane, which is an older part of Brisbane. And it is, I think the kids like where it is and the easy access to it, because it is street parking and it's just a virtual walking in with wheelchair access, etc. And so these are the good people I was referring to. This is Di Smith that you saw in the video. God bless her soul. Unfortunately, she's not with us anymore, but Di was monumental in putting the services together. And Lisa was the head physiotherapist in one of the physiotherapy firms. We had Ruben, who was a psychologist that I had kind of made contact with from my early days at the Royal Children's Hospital in Brisbane. And of course, Greg, who is a very good musician as well, and that's not just with his sideburns, but he actually is a good singer and a guitar player. And but he was one of the heads of a big podiatry firm. And we put our minds together and decided that we could indeed use the backbone of their structure to go to various clinics in Queensland in different towns, and then hold our pediatric rheumatology clinic with the support of a therapy team. So Queensland Rheumatology Services, this is one of the art pieces from an ex-patient of mine, Claudia Mudunati, who was from Arnhem Land and was brought to Brisbane, having been very unwell with her condition. And Claudia basically helped us to in the opening of Arthur House. And So as you can see, it's a very homely area, and people think that they're in grandma's house, and the kids, as a result, they don't get intimidated and they usually relax. We have other ways of relaxing them, which I will show you in a second. And so this is the gym downstairs, which is in a sort of a leafy part of the house, and nice trees around, and the kids absolutely love working with the physio there. And so this is what I was telling you about Claudia. So she officially opened Arthur House for us as a indigenous artist. This is the painting that she presented to Arthur House, and this is her life story, basically, from when she was in Arnhem Land and became sick and was carried by flying doctors, as you can see, to Royal Children's Hospital. These are the clown doctors, and then she has put me there somewhere as well. I'm painted as being very bald, which I don't know why. And this is once again, once the game was heating up, and the big team who was supporting us. And I forgot to tell you, Claudia Midunati actually won Young Australian Award in 2017, and that was just phenomenal, and we were very proud of her. And first clinic in July 2017 with the usual suspects. So there was never any shortage of smiles. And so patients were happy to be nice and comfy and be in Granny's house to be treated. And we needed additional staff to make the kids feel welcome. So this is Arthur, who's named after Arthur House. And Arthur usually sits at a chair and tries to supervise the girls to do their job properly. So we have under 15 clinics, and we called it Power Rangers and Transformers Clinic. We gave everyone a folder to organize the paperwork that they're given from the clinic or the therapist, and bring the folder to the clinic each time. And so this was one of the classes. Oh, this is actually a core strength training. Ash, one of our physiotherapists, is doing downstairs. This is Dan, our podiatrist, and assessing gait. I don't know who this patient is, I've forgotten. And this is Nicole Haynes, who's our senior physiotherapist, and this is the physiotherapy room, and very nice and friendly. And then for young adults and teens, we had the Coyote Clinic, and we were very lucky, and hopefully we will do this again. Arthritis Queensland had a grant from one of the private health organizations, I think, locally, to give that to a project for education of young adults. And so we recruited about 10 young adults between the ages of 16 and 18. And they basically completed a module which went over 8 weeks. And it was really nice. They would come in about 5:30 p.m. and I was sitting in the back room doing my paperwork after the clinic, and we had different presenters, psychologists once, James took part in giving a couple of the presentations as well, very proactive and involving the audience to be heard and say what's on their mind, and therefore it was two-way learning relationship, and I think this was valued and rated very highly. Unfortunately, as all good things, we weren't able to repeat that. But one of my projects with Zoe's Angels is hopefully to resurrect this and at least have a couple of these programs per year for the young adults. As Buffy mentioned, I won't dwell over this much more, but we have got outreach clinics in every major town along the east coast of Queensland, but also Toowoomba, which is 100 kilometers west of Brisbane. And all of these clinics are supported by allied health professionals. Just so that there is some feel good about this presentation, while psychology proved very difficult for young Ash in Claremont, I'm pleased to say that just yesterday morning I had a clinical meeting with a great psychologist in Mackay. So Pace Ahead is their name, and she's very keen, Lishan, to be involved with the multidisciplinary care of these kids. And I mean, they love it when you go regionally, because they haven't seen the spectrum of the conditions that we treat. So it is mentally very stimulating for them as well. So it is win-win situation, and everyone likes working with kids. I mean, who doesn't? And it's always very pleasant and very positive. And so this is now old news. Minister commits to National Strategic Plan for Arthritis, and unfortunately, when COVID-19 came, I think all of this is kind of on a standby mode at the moment. So a consultation draft was formed in 2018. I think that's been actually discussed and finalized. Just referring back to our family in Claremont, so Dad was in the mines, and I think his colleagues found out about his kid being unwell, and they actually, through the sort of representation there, arranged a meeting with the health minister to voice their concerns about lack of services in outback Queensland. And so everyone was very excited. So Natalie Billiard, Zoe's mum, attended with Ashlyn's mum, and so we were all very excited. And I mean, this wasn't on the day, but I found this from our Minister of Health in Queensland, a picture from the internet. But unfortunately, on the day, I think he thought that they were going to talk about meningococcal disease, and he did not have any idea that it was about arthritis in kids. They were briefed, obviously, and they engaged half an hour or so consultation with the family. And unfortunately, there was no follow through, and I emailed the minister a couple of times, finding out, you know, where, when we were going to meet again and to take it forward, but I never received a reply from the government. She had 2 further relapses of joint pain, and we are able to do video consultation with them when necessary, and also they see me at the Mackay Outreach Clinic. And I'm going to stop there. Thank you very much for your attention.
Hello, everybody. Thank you so much, Navid. That was fabulous and a very comprehensive update on what is happening in Queensland, and also what kids at different ages we need to be looking out for. It sounds like you've got a really great multidisciplinary approach happening there at Arthur's House, and I'm sure a lot of our community would be jealous and loving to have the same thing where their child is seen. Now, we've gone a little bit over time, but Navid did say that he has got a bit of time to answer some questions, so I'll get through a couple quickly. Our first question, Navid, is how severe should arthritis be before methotrexate is considered?
I think maybe severity is not the right word. It depends which joints, obviously. Okay, I think it's the chronicity of it which is more important. In other words, if you inject the joints with steroids and then they settle down, hopefully, if the arthritis keeps coming back, or if it's in multiple joints to start with, then I would have a very low threshold to start methotrexate. I think it's best to be regarded as low-dose methotrexate rather than just methotrexate because of its use in oncology, and everyone just freaks out when they hear methotrexate. It's got a really bad reverberation, but also I think it's better to call it a steroid sparing agent. In other words, you use methotrexate so you don't have to do rescue operations like joint injections and all that. For those who don't know, in younger kids, we have to give them general anesthetic every time that we need to do joint injection, especially if it's multiple joints involved. So my threshold for starting methotrexate is very low usually.
Okay, lovely, thank you. That clears that up. Second question here. The mum is saying uveitis is her daughter's issue. The daughter is 3.5 with oligoarticular JIA. They have not had success tapering off their steroid drops and will start on methotrexate soon. She's wondering if the doctor could speak more to the chance of developing cataracts or other major issues, either with uveitis that goes unresolved or with the extended use of steroid drops. How long is too long to be on these drops?
I think, once again, in Brisbane, I think we're very privileged because we have the support of Dr. Dinah Conrad, who's an expert in uveitis and shares a lot of our patients with me. And so absolutely right. The problem with uveitis is that it's inflammation in the eye. A lot of times it doesn't hurt. Therefore, you need screening to detect it. So regular screening every 3 months when the children are young is essential, unless they have got other subtypes like systemic arthritis or rheumatoid factor negative polyarthritis, which are less associated with uveitis, in which case 6 monthly might do the trick. Now, it is true, inflammation itself can be a risk factor for developing ocular complications such as cataracts, such as glaucoma, but the steroid drops, although they help when you put them in, and whilst you're on the drops, the inflammation apparently settles down. The problem with them is that as soon as they're stopped, the inflammation returns. The other thing is that they have got their side effect of increasing intraocular pressure, therefore glaucoma is a risk, as well as subcapsular cataracts that you can get, opacities in the lens. Basically, it results in having low vision for other reasons. So once again, my threshold for using systemic medication, and that means basically first one is methotrexate, is very low. In my opinion, if there is like a roller coaster ride with using steroid drops, in other words, when you're using the drops, the inflammation is done, the drops are stopped, and then the next visit, inflammation is there again. If that repeats once or twice, then that's an indication that a systemic treatment like methotrexate needs to be started. So once again, my threshold is very low, and I think it should be started earlier.
Yeah, makes sense. This question we've got in a couple of different formats, so I'm sort of blending it together, but it's basically about blood tests. How do you prepare a child, a young child, 3.5 years old, to calm her down for a blood test? Any
Well, I think it's difficult. Okay, so I often have this conversation. Like, you know, we have advanced so much in medicine technology, but taking blood from a person, I think it's still 19th century. And my anesthetist friends now, they show me good gadgets like, you know, tiny ultrasound machines that can find veins very easily for them. And I'm hoping that this can be commercialized, and then the local pathology centers can use that as well, especially for our smaller kids. Now, to be honest with you, I think probably talking with an occupational therapist would be really important to learn a few practical tricks from them. In relation, like psychologists may be beneficial with having a pediatric knowledge. Basically, you need to have a game plan before you go, because one of the worst things that happens when the little ones go there is when you have multiple operators holding the kid down to forcefully do this procedure. And I think that's traumatizing, but to be honest, at the same time, it is necessary to do, because you do need to have the blood sample to make sure that, like, say, for example, methotrexate is not doing any harm to the body. So, but the good news is that if the parents involved and reassuring the child next to the child, in other words, they realize that initially the children get confused because they realize that the parent is not protecting them against this kind of vicious person who's sticking needle in them. But with reassurance, and then especially with repeating these procedures a few times, and rewarding the child positively afterwards, they realize that actually something good can come out of it, and that even though that it hurts for a few minutes, afterwards they're good. They can go and have an ice cream with mom and dad, or they can have lots of hugs, or something that is supportive for them and will turn this negative experience to a positive one. I think that's the crux of it. If you can think of something that the child likes, but don't give it to them before the job is done, then I think that's the key. But I do acknowledge it is traumatic, but kids are really hardy as well. After a few times, they learn, and then they don't put up a fight anymore.
Yeah, great. Another one here. My daughter was diagnosed with JIA, again, oligoarticular, 2 weeks before her 3rd birthday. She's now 12 years old. Her treatment was mainly NSAIDs, and she had some interarticular injections. She was then in remission for 2.5 years, but after multiple flare-ups last year, she's now back on methotrexate for the last 9 months and doing well at the moment. She's also been treated for uveitis since she was 3 years old with steroid drops, and has been clear of any eye inflammation for quite a while now. My concern is that being on immunosuppressive medication in this current second wave of COVID outbreak in Melbourne. Also, how does puberty affect JIA? She's very active and was a competitive swimmer before COVID lockdown restrictions stopped all her usual activities. So 12 years old, living in Melbourne with COVID.
There have been lots of publications I guess none of them are a a pre-designed sort of epidemiological study to show these things that I'm about to tell you, but the initial preliminary reports and then further reports did not indicate that the population with a rheumatological condition and on medications such as low-dose methotrexate or on biologic medication had an overrepresentation in COVID-19 affected cases. In other words, COVID-19 is an extremely infectious agent. Therefore, you don't need to be on methotrexate or biologics to be able to catch it. Okay, so the mainstay of treatment is to avoid it. And so in a backhanded way, I'm giving reassurance that even if you are on these medications, there is no evidence to suggest that you have got reduced immune function. Otherwise, you would see other infections at higher rates. The only infections that you can see on biologics is mild like rhinovirus and respiratory infections. So it's a bit of reassurance to say, it doesn't really matter. I think kids with rheumatological conditions on medications are at similar risk to other people, and the best strategy is to avoid it. Also giving reassurance that it seems like the younger population are more robust against this virus, although exceptions have been known. And people are asking about the like the neonates who get affected by the COVID. Yeah, I mean, there are cases of vasculitis or Kawasaki-like illness that people might have heard about. They're very rare, and I haven't heard much report in Australia about those. But going back to the issues in relation to being on methotrexate for a long time, especially in girls, this always comes up. There are multiple studies which have been done on young females who have been on low-dose methotrexate in the past to show that they have got normal rate of pregnancy. In other words, their fertility is not affected, and normal pregnancy outcomes as normal population who are not on low-dose methotrexate. Therefore, that is not something to worry about either. Will her condition worsen or become unstable during puberty? It's a possibility. As you know, puberty is a time of flux, lots of hormonal changes in the body, and for some reason that I've never pinned down, there is a lot of change and a lot of flare-ups, so to speak, in disease activity. For that reason, in fact, I think during adolescence is the real time that you need to tighten up the medication control. I usually give the option of coming off the medications if they have completely behaved themselves and haven't had any flare-ups or exacerbation of the condition when they're in uni or when they're in their kind of 18, 19 in the first job, etc. Because then we can sort of how can I say induce remission again. There is time to do that. But in adolescence and all that probably is not the right time to do it, I don't think. The other thing that you ask is in relation to the eyes. Look, I think if she has been on ongoing eye drops for such a long time, then again, we have got different strengths of eye drops. We have got prednisolone forte, which is the strongest eye drop, and then dexamethasone, which is a little bit, that's Maxidex in the middle of the range. And then you have got weak ones like Flarex and all that. So probably it's okay to be on Flarex for a long time. But at the end of the day, I think methotrexate is the one that will prevent the flare-ups of uveitis. And don't forget that we have got biologic access to Humira as well. And if you talk to your pediatric rheumatologist, there is, with thanks to AbbVie, they have a compassionate program, and without charging anyone, if a person has uveitis, this is how Medicare rules really drive us crazy, the pediatric rheumatologists, because I don't think they have been in consultation or appropriate consultation with ped rooms. A young child with uveitis currently cannot have biologic from Medicare. So we have to go with a hat in our hand to the drug companies and beg them for biologics because they're very expensive, as many of you know. So, but nevertheless, don't forget that we have got access to compassionate Humira. Therefore, if with methotrexate you still need eye drops, maybe you can have a chat to your ped room about possibility of getting Humira, because I've had many patients like that and they've settled down and they don't need eye drops anymore. And the good news is that then you can reduce the dose of methotrexate as well and leave it like 5 milligram, 10 milligrams, something like that, that doesn't cause any side effects.
Okay, lovely, thank you. I think we might just do one more quick question, if that's all right.
Of course.
We've got a lot of questions through, which is fabulous. And what we'll do to everyone that hasn't, whose question we're not going to be able to get to tonight, is that we will get back to you via email over the next week or two. So thank you so much for all your questions. They're really great. Navid, what do you think is the most important message that parents can give to their child's school regarding juvenile arthritis?
I think there are formal documentation. In Queensland, we have got AVT, which is Advisory Visiting Teachers. I'm sure in different states they have different names. So these teachers are liaison between families and doctors and school to inform the school formally that there is a chronic condition there. The doctor usually is involved in actually specifying what the considerations might be. But the message to give to school, it really needs to be tailor-made to the child, because as I mentioned in my presentation, some kids don't like other peers to know, especially in adolescent years. And so that's really important to protect the anonymity of the child and then respect their wish. At the same time, if they don't mind to tell the school that the child might need to get up after 20-25 minutes of sitting down and then go outside and do a 5-minute brief stretch and like a joint program that the physio might have taught them, and that should be okay. If they're doing sport and the child is in pain or is fatigued, to be able to have a few minutes to recover before joining back in. But I think everyone needs to be on the same page, including the young person, that this is not a kind of means of getting out of doing sport, but at the same time, the school should not be overprotecting by sending the child to the library to read whilst everyone is having fun outside. I think inclusion is one of the most important things that will define quality of life for the kid, and exclusion is something that everyone has problems with, and obviously they don't they want the anonymity to be preserved because they don't want to be excluded.
Yeah, totally agree. Just a reminder to everyone, on our website, we've got our school resources, and within that pack there is a booklet that you can share with your child's school, and it covers off a lot of those issues. It also has at the back an individual healthcare plan to complete with your child's rheumatologist, so that the school can have up-to-date information on exactly the issues that affect your child. So have a look online for that, or email me if you'd like me to post you a copy. So Navid, I think we need to wrap up now. Thank you so much for your time tonight. I'm sure everyone has found that invaluable. As I said, there is some questions that we didn't get to, which we will endeavour to get back to everyone with their answers. And everyone that registered for the webinar tonight will receive a link to watch it again. So you probably all had some issues with sound early on, sorry about that. You'll be able to watch it again in your own time. So thanks again. A little survey will pop up. We'd appreciate your feedback if you can, and keep well, and we'll see you at the next MSK Kids webinar. Good night.
Thank you so much. Thank you.